In this lecture today, we are going to look at vascular physiology. We'll be focusing on the structure of blood vessels and the physiology of blood vessels. And you'll also be looking at blood pressure. Perhaps in particular, the first thing we're going to look at are the varieties of blood vessels. And we are going to state the different parts of the circulation as well. After that, we are going to look at the tissue components that make up the vascular wall. And in that process, we'll be talking about the structure of blood vessels, basically. Then we look at the vascular dynamics and those parameters that determine the blood pressure. And eventually, we look at how the blood pressure is regulated, both on a short-term basis and on a long-term basis. So let's start with that first one. Now, we know that from the heart, we have arteries which carry blood away from the heart. The blood in the artery is usually at high pressures. Arteries divide into smaller vessels, which we call arterioles. Arterioles have narrower lumen, and their wall usually can contract significantly to narrow the lumen further or relax to widen the lumen. For that reason, arterioles are the ones that largely control the vascular dynamics and blood pressure. From the arterioles, blood goes to capillaries, which are exchange units. So they have very thin walls to enable them exchange substances between bloodstream and the tissues. From the capillaries, we have veins, which now collect blood from the tissues. But before we have the large veins, the smaller veins are called venules. So from the capillaries, you have venules, which take deoxygenated blood from the tissues, gradually joining to form the larger veins. And those larger veins are the ones that will now be carrying blood to the heart. Now, the larger veins, their walls are very pliable. Then they can distend a lot. For that reason, veins are able to accommodate large volumes of blood. Much of blood is stored within the veins than in the arteries. So this image shows us what you've said. From the heart, we have arteries, then arterioles, then capillaries, then venules and veins, and then back to the heart. That is a complete one circuit. This also shows us that from the arteries, we have arterioles, then capillaries, which are the exchange units. So you can see for capillaries, we have the arterial end of the capillary and the venous end of the capillary. These are the exchange units. Then thereafter, you have the veins joining back to the heart. But there's something I want to say here. From the heart, we've said that you have arteries. Histologically, there are different types of arteries, as we're going to see. The larger arteries are called elastic arteries. Their aim is just to conduct the blood, and as they do that, they maintain the blood pressure of blood. Then we have muscular arteries from a histological point of view, which now distribute that blood to the different body regions. Then from the muscular arteries, that's when you have the arterioles. So I've just broken down the arteries into elastic type of arteries and muscular type of arteries, and we are going to see the histological basis of that distinction. But coming back to the capillary bed, From the capillaries, we see that you may have, yes, blood joining the venules and then back to the veins, but some fluid does not go to the venous side. Some fluid go to the lymphatic channels. And so lymphatic channels will carry that fluid back to the lymphatic system. So it will go through some lymph nodes, then to the larger lymphatic vessels. The largest in the body is called the thoracic duct, which then takes that fluid back to the venous system before it goes to the heart. So that's what I wanted you to capture in that particular image there, that fluid can still come from the interstitial tissue and follow the lymphatic channel, but some fluid also go back to the venous circulation. What are the parts of the circulation? There are two parts of the circulation. We have the pulmonary circulation, which refers to the exchange between the heart and the lungs. And we have the systemic circulation, which refers to the exchange between the heart and the rest of the body tissues. So that is systemic circulation, and this is pulmonary circulation. From the first image, we see that the systemic circulation goes back, the blood from the systemic circulation goes back to the heart through two channels. Can go back to the heart through the superior vena cava, and that will refer to the blood coming from the upper part of the body, the junction being the thoracic diaphragm. And the blood coming back to the heart from the lower part of the body, the junction still being thoracic diaphragm, will enter via the inferior vena cava. So whether it comes from the superior vena cava or inferior vena cava, that is still systemic circulation. Back to this second image, there's something I want to capture here. In the previous image, in the previous slide, we talked of heart giving you arteries, then arterials, capillaries, venules, and then veins back to the heart. Or we can keep it simple this way. From the heart, you have the arteries, then capillary bed, then veins, and then back to the heart. As you can see here, arteries, capillaries, veins, back to the heart. There are some situations where that is not the case. In those situations, you may have two capillary beds in one circuit. You see, in this one, we only have one capillary bed in this particular circuit. How about this one here? You have one capillary bed there, another venous vascular channel, then another capillary bed, then back to the heart. When you have two capillary beds in one circuit, we call that a portal system. That's the spelling of portal. So a portal system is the existence of two capillary beds in one cardiovascular circuit. In that case, you'll have the heart, then arteries, then capillary, which means an organ. Then there's another vascular channel that connects to another capillary bed, which means another organ. And then now vessels which take blood to the heart. Portal systems are there in the body. And I want to give you three sites where we have portal systems in the body. The largest is this one here, where blood comes from the heart to the arteries, then go to the intestines. So we have capillary beds there. Then from the intestines, you have a vessel that take that blood to the liver. Within the liver, you have another capillary bed. Then from the liver, you have veins which take blood back to the heart. Therefore, we see that you have two capillary beds in that particular circuit. We call that portal system the hepatic portal system. Hepatic portal system. The other portal system is existent between the hypothalamus and the pituitary gland, where blood vessels go to the hypothalamus. There's a capillary bed there. Then there's vascular connection between hypothalamus and the pituitary gland. Then in the pituitary gland, there's another capillary bed. So we see two capillary beds in that one circuit. We call that the hypothalamo-hypophyseal portal system. Hypothalamo-hypophyseal portal system ensures that some hormonal substances produced by the hypothalamus travel via bloodstream to the pituitary gland to control secretions of the hormones of the anterior pituitary gland. The third site where we have another portal system is in the kidney. So in the kidney, we have blood vessels which join which branch down to go to the glomerulus. So that at the glomerulus, we have a capillary bed. From the glomerulus, you have vascular channels, which again connect and form another capillary bed around the proximal and the distal convoluted tubule, so that you have another capillary bed there. So we have the glomerular capillary, then efferent arterial, and then peritubular capillaries. So you have two capillary beds in the kidney. So that's also another example of a portal system. Those three examples are enough. At least you now know what a portal system is. There are some pathological situations where a capillary bed is not existent. So blood in the arteries joined to the veins direct. We call those ones arteriovenous shunts. Arteriovenous shunts, where blood in the arteries go direct to the veins without passing through capillaries. Arteriovenous shunts. Most of them are pathologic though. All right, so that is the story about the different varieties of blood vessels and the different types of circulation. Now let's address the second agenda. We talk about the tissue components of the vascular wall, and we'll also state their role. A vascular wall is described to have three layers. These are the three layers. The innermost layer, Tunica Intima, the middle layer, Tunica Media, outermost layer, Tunica Adventitia. Let's talk about each of the layers. Let's start with the innermost layer, Tunica Intima. So that's the Tunica Intima. The Tunica Intima is lined by endothelial cells. Usually endothelium is simple squamous epithelium. And that endothelium forms a barrier between blood and the tissues. Now, in larger vessels, there'll be some tissue below the endothelial lining. Like in this vessel I'm showing you, this is the lumen, and this is the Tunica Intima. This is Tunica Media, and that's Tunica Adventitia. So in some vessels, the larger ones, you'll have some tissue beneath the endothelial lining. That loose connective tissue beneath the endothelial lining is known as the subendothelial zone. The subendothelial zone is still part of the Tunica Intima. And between the Tunica Intima and the Tunica Media, there's usually a layer of elastic fiber. The elastic fibers form some convoluted lining, which we call the internal elastic lamina. So that wavy thing you're seeing is made up of elastic fibers. and highly coiled like that, we call it the internal elastic lamina. The internal elastic lamina is also part of the tunica intima. So if you are to state the components of the tunica intima, especially in larger vessel, you'll talk of the endothelial lining, the subendothelial zone, and the internal elastic lamina. I've already told you one of the functions of endothelial cells, that they form a barrier between bloodstream and the tissues. But we know that endothelial cells can also initiate the process of blood clotting, can initiate the process of hemostasis. Another role is that endothelial cells produce some vasoactive substances, chemical substances which have the capacity of regulating the lumen of blood vessels. Okay, that is tunica intima. Now let's talk about the tunica media. This is the tunica media. Usually that layer contains vascular smooth muscles. It also contains the elastic fibers and collagen fibers. This image captures that. This is the tunica media, which contain vascular smooth muscle. That's how smooth muscle looks like. It also contains collagen fibers and elastic fibers within this region. What is the main role of the tunica media? The smooth muscles that the tunica media contain are important in the vascular dynamics. When the smooth muscles contract, the lumen of the blood vessel narrows. And when the smooth muscles relax, the lumen of the blood vessel widens. And so they're important in controlling the vascular dynamics. Because they control vascular dynamics, they affect blood pressure. The tunica media is the one that influences blood pressure predominantly. The elastic fibers within the tunica media are primarily for maintaining blood pressure. It's because they can recoil, and when they recoil, the blood vessel does not lose much of its pressure. So it's for maintenance of blood pressure. Like in this image, we see a vascular wall with several elastic fiber lamellae along the wall. It tells you that this blood vessel is primarily for maintaining blood pressure, to avoid so much oscillations despite the pumping of the heart. The collagen fibers that are usually within the tunica media are responsible for providing strength to the vascular wall so that the vessel does not balloon out unnecessarily. It prevents aneurysmal dilatations. That's tunica media. Now let's talk about tunica adventitia. The tunica adventitia is the outermost layer. This outermost layer contains collagen fibers predominantly. And the collagen fibers in the tunica adventitia are responsible for providing strength as well. The strength is required to prevent overdistension. In larger blood vessels, the tunica adventitia will contain some smaller blood vessels. The small blood vessels within the tunica adventitia of large blood vessels is known as vasa vasorum. So things like aorta will have vasa vasorum. All right. Based on what I've described for you, I want us to now talk about histological types of arteries. We classify arteries histologically based on the amount of smooth muscle and elastic fibers which are present within their tunica media. On this basis, we usually talk about 4 histological types of arteries. The first one look like this. We call it elastic arteries. It has a very thick tunica media, and that tunica media has several elastic fibers. In this image, perhaps the ones in, I don't know how to call that color. I would have called it blue, but I have a feeling I might be wrong. Anyway, that one. So the ones that look like that, those are elastic fibers. An elastic artery has several elastic fibers. What else do we notice about an elastic artery? It has a very thin tunica adventitia. The tunica adventitia is thin. The tunica media is thick, and it contains a lot of elastic fibers. This applies to very large arteries, like the aorta and common carotid artery. The second histological type is muscular artery. The unique thing about muscular artery is that it has a very thick tunica adventitia, as you can see there. It also has a very prominent internal elastic lamina. This is the prominent internal elastic lamina that it has. And then the tunica media of muscular arteries has predominant vascular smooth muscle. So there's more vascular smooth muscle within the tunica media. The third histological type of arteries, which is not in this slide, is what we call hybrid arteries. Hybrid arteries is where you have a combination of those two. If you have amalgamation of those two, we call that hybrid artery. And a good example of hybrid arteries are the coronary arteries. I forgot to tell you examples of muscular arteries. Most arteries in the body are actually muscular arteries. So those arteries you know in the limbs, the arteries that are in the upper limb, like brachial artery, radial artery, ulnar artery, the ones in the lower limb, femoral artery, popliteal artery, anterior tibial, posterior tibial, all those are muscular arteries. The fourth histological type of artery is the arterial in particular. So what is unique about the arterial? The tunica adventitia is thin. The internal elastic lamina is prominent. It has hardly any elastic fibers within the tunica media. So the tunica media is predominantly just smooth muscles and hardly any elastic fibers within the tunica media. Remember that the lumen of arterial is very tiny. If you look at the arterioles in particular, you notice that they may not even be having the subendothelial zone. Look at that. It's just the endothelial lining and the internal elastic lamina. We don't have the subendothelial zone, but we had it here, and we also had it there. So those are the 4 histological types of arteries: elastic artery, muscular artery, hybrid artery, and arterioles. So this image shows us a histological slide of a blood vessel. We want to determine which histological type of blood vessel is this. So we see a thick tunica media. That is tunica adventitia. It is lacking or almost lacking on that side. At a higher magnification, that is still the tunica adventitia. We can see it's thin. That is tunica intima, also not very prominent. We don't see a prominent internal elastic lamina, but the tunica media seems to have some lamellae. And a high magnification shows that there are several lamellae within the tunica media, which is very thick. This is an elastic artery, like aorta is an example. In this other image, we still see a blood vessel. So that's the lumen, this is the wall, that's tunica adventitia. This tunica adventitia seems more prominent than the previous one. But a closer look at the wall still displays that the tunica media contains several layers of elastic fibers. Those black wavy things are the elastic fiber. They're in lamellar layers. So as long as we can see a lot of elastic fiber lamellae within the tunica media, and the internal elastic lamina is not prominent, that is still an elastic artery. But let's look at this one. So this one, the tunica adventitia, is really prominent, as we can see. That's the tunica media, and the internal elastic lamina is also very prominent. I can see it even at that magnification there. Maybe this magnification makes the internal elastic lamina better. We can see that wavy thing. Very prominent internal elastic lamina, prominent tunica adventitia, and that is the tunica media, which is largely made up of smooth muscles. And so this one here is muscular artery. So that's how we distinguish blood vessels. I've shown you how muscular artery looks like, and I've shown you how elastic artery looks like. Let's give examples of major arteries in the body. Now this we cannot really do in one sitting where I teach you the arteries in the body. It's not possible. But I want you at your own time to just take an atlas of the arterial system and study the arteries of the body. So from the heart, you know, we have the aorta, ascending aorta, arc, and the descending aorta. What are the branches of the ascending aorta? What are the branches of the arc? What are the branches of the descending aorta? Then you also follow those branches and see how they branch further away from the body. Take time and go through that slowly. You don't have to do it over one day. You can decide today you do the ones in the head region. Another day you do the ones in the upper limb. Then maybe the ones in the trunk, and then the ones in the lower limb. Just slowly. But closely related to that, because we need to understand this from a clinical perspective, I want you to take some time and look at that. I want you to name the various sites in the body where we can feel arterial pulsation. So this will help you to understand the arterial of the body. And once you've mentioned those sites where you can feel the arterial pulsations, I also want you to mention the artery responsible for that pulsation in each case. For example, let's start with the most obvious one. So one of the sites where you can feel pulsations is the anterior wrist, on the lateral aspect of the anterior wrist. So that is a site. Anterior wrist laterally. And now the artery there is the radial artery. So that's what I want you to do for the other sites. So after that exercise, we can now talk about the structure of capillaries. We've talked about structure of arteries. What the histological structure of capillaries? This is how capillaries are organized. A capillary consists of one layer of endothelial cells and their basement membrane. So we are not talking about tunica adventitia, tunica media, and tunica intima when you're talking about capillaries. It is just one layer of endothelial cells. And because endothelial cells are epithelial cells, they have a basement membrane. So here, that is a layer of endothelial cells. And that's the basement membrane of endothelial cells. Even that one, that's a layer of endothelial cells, and that's the basement membrane, even that one. Based on the organization of the endothelium and its basement membrane, there are three histological types of capillaries: continuous capillaries, fenestrated capillaries, and sinusoidal capillaries. Let's see them. I'll use this image to describe the structure of those capillaries. We start with the continuous capillary. I'm using the red line to represent the basement membrane of the endothelium. And I'm using those ones to represent the endothelial cells. So what do we see? We see that the endothelial cells form one layer, and they're attached to one another, as you can see there and there and there. The endothelial cells are continuously attached. The basement membrane is continuous and intact. We don't see any gap between the endothelial cells. Neither do we see gaps within the basement membrane. This is the lumen of the capillary. And of course, this is the other wall, the other side. So capillaries which look like this are called continuous capillaries. The endothelial cells are continuously attached. The basement membrane is intact. There are no gaps between or within the endothelial cells. Continuous capillaries are found in the central nervous system. We find them in adipose tissue. We find them in skeletal muscles. They're the same ones which are also found on the skin. Those are continuous capillaries. The second type of capillaries look like this. Now look at that. Let's start with the basement membrane. It looks intact throughout. That's okay. Look at the gaps between endothelial cells. The endothelial cells are attached to one another again, just like continuous capillaries. There are no gaps between endothelial cells. But we see gaps through the endothelium. The endothelial cells have some holes through them. These holes are known as fenestra. The term fenestra means window. So capillaries that have windows through the endothelial cells are known as fenestrated capillaries. Such capillaries are found in the renal glomerulus. We also find them in the villi of the small intestines. We find them in endocrine glands. Such capillaries facilitate movement of substances. But usually it's a controlled movement of substances. Then we have what we call sinusoidal capillaries. You can call them discontinuous capillaries. Look at that basement membrane, we can see it is interrupted. And look at the gaps between endothelial cells, we can see that there are gaps. Well, the endothelium itself is intact. There are no holes through the endothelium, but there are gaps between endothelial cells. So these are the ones we call discontinuous capillaries. We find them in the liver. We also find them in lymphoid organs. So we call them discontinuous capillaries or sinusoidal capillaries. So sinusoidal is just this one, just remove that S and put AD. Sinusoidal capillaries. Those are the different types of capillaries that we do have. What is the structure of the capillary bed? This is the structure of the capillary bed. So a blood vessel, the arteries come, divide into arterioles. The last arterial is what I'm calling the terminal arterial here. The terminal arterial gives you a vessel which is supposed to be a capillary, but we call it meta-arterial, and I'll tell you why. So the meta-arterial comes out. The aim now is to supply tissues. The meta-arterial gives you some smaller capillaries which branch off it, but before they branch, there's a sphincteric muscle around that vessel. We call that sphincteric muscle the precapillary sphincter. So those vessels which have precapillary sphincters are known as the true capillaries. But this meta-arterial is a false capillary. Why do we say that the meta-arterial is a false capillary? The meta-arterial is a false capillary because the blood in the meta-arterial is not so much involved in exchange of substances. As a matter of fact, the blood in the meta-arterial usually just go through the organ and join with a venous channel, which we now call the thoroughfare channel. The thoroughfare channel is the channel on the venous side. So that thoroughfare channel is continuous with the meta-arterial. And that path is not so much involved in exchange, minimal. I'm not saying zero, but minimal involved in exchange of substances for blood to go to the vein. But the true capillaries have a sphincteric mechanism at their origin. And that means that that muscle can contract and block blood flow through that capillary. So actually controlling exchange in that particular vascular bed. Those are the true capillaries. Now, why do we have such arrangement? There are some circumstances where we don't want blood to go to a particular organ for whatever reason. In that case, those precapillary sphincters will contract so that blood does not go through the true capillaries. So it will just be minimal. So in those circumstances, if you totally block here, you know you're going to increase blood pressure. So that is when the meta-arterial comes into play, because now blood in the meta-arterial will join to the capillary, and that means that you'll have an arteriovenous shunt. That arteriovenous shunting is a mechanism of ensuring that blood still goes back to the heart, even if you don't want much blood to supply a particular organ. This is a mechanism of bypassing blood to the venous side. All right, so that's the structure of capillary beds. The role of the precapillary sphincters is to control blood flow to an individual organ. That's the structure of capillaries. Now let's talk about the structure of the veins. Now the veins will have similar structure like that of arteries: tunica externa or adventitia, tunica media, and tunica intima. The only difference is that now for veins, the tunica media is thinner. They have thin tunica media. The other unique thing about the veins is that they have wider lumen compared to the corresponding artery. So veins have wider lumen compared to the corresponding artery. They have thinner tunica media compared to the corresponding artery. Veins do not have the internal elastic lamina. They don't have the internal elastic lamina. The arteries have. But importantly, the veins have valves which allow blood flow in one direction. The arteries don't have the valves, but the veins have the valves. Those are the differences between arteries and veins. Now, because of the wider lumen, veins tend to hold a lot of blood compared to the rest of the circulation. At any given time, about 60% to sometimes even 70% of the blood is in the veins. Then the rest is in the systemic arteries, pulmonary vasculature, the heart, and capillaries. But systemic veins hold 60 to 70% of blood. Why? Because they have wider lumen, so they are more compliant vessels. They can hold much blood. And so they are a form of blood reservoir in particular. Okay, just like what we said for the arteries, you also need to do that for the veins. So as you study the arteries of a particular region, just study the corresponding veins for that particular region as well. Using an atlas, we can't do this in one sitting. Good, now I want us to talk about vascular dynamics and the determinants of blood pressure. For you to understand vascular dynamics and the determinants of blood pressure, you need some fresh mind. So let's log into that. First, let's begin by defining some terminologies. The first terminology I want us to define is blood flow. We abbreviate it as F. Blood flow refers to the volume of blood that is flowing through a blood vessel. So let me say this again. Blood flow is the volume of blood that is flowing through a blood vessel, an organ, or the entire circulation in a given period of time. We measure blood flow in ml per minute. The blood that flows in a particular organ varies according to the immediate needs of that particular organ. For example, the blood that is flowing through the liver may be enhanced or decreased. the blood that is flowing through skeletal muscles in a state of emergency may be increased for that particular moment. Blood that flows to the kidney may be increased. The one that goes to the heart when you're performing an activity may be increased. The one that goes to the skin because there is a lot of high heat in the body, the blood may also increase at that particular moment. And if it's very cold, the blood that's going to the skin may reduce by vasoconstriction. So usually the blood flow to an organ will vary a lot depending on the needs. When that variation takes place, we may not necessarily affect the overall cardiac output. Usually what happens is that you have redistribution of blood from one place to another. So some organs will take more while others take less, so that the overall blood flow to the body, which we call cardiac output, may not change much, but the ones that go to particular organs vary a lot. So understand, therefore, that if you look at blood flow to the entire vascular system, that is what we call cardiac output. The amount of blood pumped from either ventricle in 1 minute. That is what we call cardiac output. So that cardiac output doesn't change much, even when these organs change. I'm not saying it doesn't change. I'm just saying it doesn't change much because there's a lot of redistribution between one organ and another one. There's some mathematical relationship that I want you to understand at this point between blood flow, blood pressure, and resistance. And in the subsequent slides, we are going to define what is blood pressure. We'll also define what is resistance. Blood flow is directly proportional to the pressure difference between 2 points in the circulation. Let's put that this way. Imagine the aorta and also the anterior tibial artery. So those are 2 points in the circulation. The blood flow between the aorta to the anterior tibial artery is directly proportional to the pressure difference between those 2 points. So look at the pressure in the aorta, look at the pressure in the anterior tibial artery. The pressure difference between those ones will determine the blood flow. So if the difference in pressures are high, then the blood flow will be high. If there is 0 pressure difference, there'll be no blood flow. If the pressure in the anterior tibial is higher than the one in the aorta, maybe you'll even have a reversal of blood flow. So I'm saying that blood flow is directly proportional to the pressure difference between 2 points in the circulation. However, blood flow is inversely proportional to the resistance to blood flow. The factors that prevent that blood from flowing is what we call the resistance. So if there's a lot of resistance, let's say there's occlusion, that's resistance. So that will inhibit blood flow. So if you are to have a mathematical relationship between those 3 factors, then you can say F is equals to change in pressure divided by resistance. F is equals to change in pressure divided by resistance. So have that mathematical formula in your head. We will use it when we are going to work out the formula for blood pressure. The second thing I want us to define is the blood pressure. Blood pressure is the lateral force that is exerted by blood on the vascular wall per unit area. Lateral force. Remember, blood flows longitudinally along the lumen. But there's some force that blood puts on the vessel. That's the lateral force. So the force that the blood exerts on the vascular wall per unit area is what we call blood pressure. That force is created by the pumping action of the heart. When the heart pumps that force during systole, the pressure is high. So it's created by the pumping activity of the heart. Because it is created by the pumping activity of the heart, the pressure therefore usually rises in the arteries during contraction of the heart, during cardiac systole. And the pressure falls to its minimum when the heart is in relaxation. And so arterial blood pressure oscillates between that maximum and minimum in each cardiac cycle. That may not be the case for the pressures in the capillaries and the pressures in the veins, and I'll tell you why shortly. What I mean is that the pressures in the capillaries and the pressures in the veins do not necessarily oscillate, but the ones in the arteries oscillate. So that tells you, if somebody ever asks you to talk about the capillary pressure, don't give it like something over something. The way you give the one for arteries, even the one for veins, don't give it as something over something, because the pressure does not oscillate between maximum and minimum. It's a uniform. But for arteries, we want to know systolic and the diastolic pressure. Let's define vascular resistance. Vascular resistance is the opposition to blood flow. The things that oppose the flow of blood. And basically, it is a measure of the amount of friction that blood encounters as it goes through blood vessels. This resistance is determined by three major factors. One of them is the viscosity of blood. If the blood is very thick, the resistance will be high. And so the pressure will be high. Or let me put it this way. If the blood is very thick, then the blood flow will be low, because it said that blood flow is inversely proportional to resistance. So if the blood is viscous, it means that the resistance is high, and so blood flow will be low in that case. What will make blood to be thick? Maybe polycythemia, for example. You have a high red blood cell count, so the blood is relatively thick in that case. If the blood is less viscous, it's thin in that matter, it means that the resistance is low in that case. And maybe some forms of dilution may make the blood to be very thin. So less resistance. The length of the blood vessel is also the second factor that will determine resistance of blood vessels, of resistance to flow. The longer the vessel, the higher the resistance. The shorter the vessel, the lower the resistance. But most importantly, this one, vascular diameter. If the lumen of the vessel is wide, it means that less molecules of blood will actually be hitting the wall of that vessel. And so the resistance is low. But if the lumen of the vessel is narrow, it means that most of the molecules of blood at any given time are actually hitting the wall of the vessel. And so the resistance is high. Maybe let's look at it this way. Imagine blood flowing through a river. And I know at some point we've all watched water flowing in a river. At some point we've watched a stream in a river. And maybe a big river. If you look at the speed at which water flows in a river, you'll notice that the water near the riverbank is hardly moving. But the water at the center of the river is moving fastest. Why? Because the water near the riverbank is experiencing resistance, and so the flow is reduced. But the water at the center of the riverbank is not hitting the wall of the riverbank, and so minimal resistance. So if you imagine that in the arteries, if the vessel had a wider lumen, it means more and more blood tissue will be not hitting the lumen, the wall, and so the flow is increased. But if the vessel is narrow, it means that a bigger proportion at any given time in any cross-sectional area, a bigger proportion of blood tissue is actually hitting the vascular wall, and so experiencing a lot of resistance. The narrower the lumen, the higher the resistance. The wider the lumen, the lower the resistance. Now, I want you to understand these three parameters well, that they're the ones that contribute to resistance. But look at them again from a very physiological, a very practical point of view. The length of the blood vessel is not a variable that we can change. You might be tall, but that's it. You're always tall. You might be short, but that's it. You're always short. So it's not a variable that we can change, even though it's a factor. Blood viscosity does not change over time, like rapidly, so to speak, unless there's some pathological condition that has happened. So even though we are saying that there are three principal factors that contribute to resistance to flow, the main physiological factor that will determine them is the vascular diameter. Because arteries and arterioles vasoconstrict and vasodilate any given time, even within seconds. And so that third parameter is a major determinant of resistance to blood flow from a very physiological point of view, or from a practical point of view, so to speak. Now, based on those things we've said, much of the narrower blood vessels will be the ones away from the heart, as opposed to the ones closer to the heart. Remember, the aorta and pulmonary trunk are closer to the heart. They are very wide. So they don't give us much resistance. Even the larger branches of the aorta are still having wide lumen, and so they don't give us much resistance. But as you move further away from the heart, the lumen of the vessels narrow. And so there's a lot of resistance away from the heart. I want you to understand, therefore, that even though we are saying vascular diameter is a major determinant to resistance, the one that contributes to resistance, much of that is experienced away from the heart rather than closer to the heart. And so the term we commonly give resistance is peripheral resistance, because that's the one that is most significant, peripheral resistance. I hope you've understood resistance. And now I want you to work through that mathematical formula that I gave you earlier. I told you that F is equals to change in P over R. Now, I want to give you some 30 seconds to rearrange that formula and give me and work out maybe what is the calculation for R. R will be equals to what? Also at the same time, work out the formula for getting P. P will be equal to what? Based on that formula that I've given you of F is equals to change in P over R. You have 30 seconds for that. Right, I hope you've organized that formula. Have it somewhere. We are going to use it shortly. Let's see how blood pressure changes in different vascular beds. The normal blood pressure for the arteries, I told you, will oscillate between systolic and diastolic. And the normal one is usually about 120 for systolic and 80 for diastolic. The unit is millimeters of mercury. And this graph shows us that very well. As we move from the aorta to the large arteries and even the smaller arteries, the blood pressure will be oscillating between systolic and diastolic. And that's okay. Now, as the blood pressure, as the blood moves away from the heart, we can see that the pressure falls progressively. There's a progressive decline in the blood pressure as we move away from the heart. Look at what we see in the arterioles. Now the pressure is reducing. Also notice that in the arterioles, the oscillations are also reducing. So that now by the time we arrive in the veins, in the capillaries, sorry, we do not have the oscillations anymore, as I told you. The pressure in the capillaries has reduced significantly, so that the arterial end of the capillary, which means the beginning of the capillary, the blood pressure is about 35 millimeters of mercury. And at the venous end of the capillary, the pressure is between 10 to 17 millimeters of mercury. And that will depend on the blood flow in that organ. It will also depend on, remember what we talked about, the precapillary sphincters. It will depend on the activity of those ones. And that's why we have a variation at the venous end. That blood still falls down so that when the venules and in the veins, the blood pressure goes to almost zero. So there's almost 0 millimeters of mercury at the termination of the vena cava. There's very little pressure, almost 0 at the vena cava, or actually 0. Luckily, that blood enters the heart, again, the right heart chambers. And so the heart will pump it again to the pulmonary circulation. And so the pressure will rise again. And remember, because the heart pumps, systolic and diastolic will have oscillations. The pulmonary pressures will be about 20 systolic and 10 they are diastolic. And those are the normal pulmonary pressures. Well, can be from 8 here, diastolic, to 20 there, or 18, 20 there for systolic. Maybe what I want to capture is that the pressures in the pulmonary circulation are normally much lower than the pressures in the systemic circulation. You need to capture that one. And that is why the left heart chambers have higher pressures than the right heart chambers postnatally. Great. Now let's narrow down to the arterial blood pressure, the blood pressure within the arteries. I've already told you that the normal arterial blood pressure will oscillate between systolic high and diastolic low. The difference between the systolic and the diastolic pressure is known as the pulse pressure. So in this case, we can say that the normal pulse pressure is 120 minus 80, which gives us 40 millimeters of mercury. At any given time, as blood flows in a circulation, the diastolic pressure usually lasts longer period than the systolic pressure. And you saw that even when we talked about the cardiac cycle. Blood moves out of the heart only in one of those situations. Out of those 6 phases of the cardiac cycle, the blood moves out of the heart only during ventricular ejection. And so that's the time we have the systolic pressure. But all this other time, we don't have the systolic pressure, we have the diastolic pressure. And so the diastolic pressure lasts longer than the systolic pressure. What's the implication of that? The implication is that if you are to calculate the mean arterial blood pressure, we can't just say it is 120 plus 80 over 2 to get 100. That can't work. Because we are saying that diastolic pressure lasts longer than the systolic pressure, which means that the diastolic pressure has more predominance in determining the mean arterial pressure than what the systolic pressure has. From a mathematical point of view, it has been noted that 2/3 of that will be given to the diastolic pressure and 1/3 will be given to the systolic pressure. So therefore, if you are to calculate the mean arterial pressure, we'll have to give more dominance to the diastolic pressure than to the systolic pressure. Now, without boring you with too much of mathematics, this is how we do it. If you want to calculate the mean arterial pressure, you take the pulse pressure divided by 3. So that 1/3 of the pulse pressure, you add it to the diastolic pressure. And that will give you the mean arterial pressure. So you can try that one here. 120 minus 80 is 40. That's the pulse pressure. 40 divided by 3 will give you roughly 13. So 13 is the 1/3 of the pulse pressure. You take that 13 and add it to the diastolic pressure, which is 80. You get 93. So when the blood pressure is 120 over 80 millimeters of mercury, the mean arterial pressure is 93 millimeters of mercury and not 100. You've noticed that through that formula, we've given much predominance, much weight, much influence of the diastolic pressure than on the systolic pressure. So the normal mean arterial pressure is 93 millimeters of mercury. Usually above 90 millimeters of mercury is a normal mean arterial blood pressure. What I want to capture is that when you calculate the mean arterial blood pressure, you're not just adding the two, then divide by 2. They don't have equal contribution to the mean arterial pressure. All right, so this graph shows us we have the systolic and the diastolic pressure, but that's the mean arterial pressure. The diastolic has a greater influence than the systolic. So the mean arterial pressure will not be in the middle of that, but somewhere lower. And as I told you, the mean arterial pressure declines progressively as we move away from the heart. So that when we're in the arterials, we lose it so much. By the time we are starting the capillaries, we don't have. Okay, let me put it this way. The mean arterial blood pressure reduces, that one we've agreed. The pulsations, the oscillations in the systolic and diastolic pressure also reduces significantly as you move away from the heart. So the arteries have the oscillations. The arterials to some extent also have the oscillations, but we can see the oscillations are reducing. So that by the time we are starting the capillaries, we don't actually have the oscillations. That is why I told you that the arterial end of the capillaries will have it at about 35 millimeters of mercury, and we are not giving something over something. And then the venous end of the capillary will have between 10 to 17 millimeters of mercury. Again, we are not giving something over something. So we don't have the oscillations here. The pulse pressure has disappeared as we move along. Okay, now let's talk about the capillary blood pressure. Maybe it will just be a repetition, but I want you to capture that we have arterial blood pressure, we have capillary blood pressure, and we have venous blood pressure as well. So by the time we're starting the capillaries, the pressure has reduced to 35 millimeters of mercury. By the time we are on the venous end of the capillaries, we have about 10 to 17 millimeters of mercury. Maybe then we state, why do we need these low pressures in the capillaries? Capillaries are very fragile. Their walls are very weak, as we saw, only endothelium and its basement membrane. If you are to have high pressures, you'll rupture the capillaries. So those lower pressures are desirable. But again, the other reason is that capillaries are extremely permeable. Substance can move freely because they have very thin walls. And so even those very low pressures are adequate to actually force substances to move out of the capillaries into the interstitial space. The pressure is enough to move substances. So you don't need higher pressures for that person. How about the venous pressure? The venous pressure is steady and changes very little during the cardiac cycle. I've already told you that it doesn't have the oscillations. The pressure gradient in the veins from the venules to the end of the vena cava is very low as well. Now we saw that the end of the capillaries, we were just having 10 to 17. If you look at the pressure gradient from the venules back to the vena cava, we said that vena cava was having almost 0. And the venous end of the capillaries have about 17. If you subtract the two, the pressure gradient between the venules and the vena cava is only about 10 to 15 millimeters of mercury. This is very low. And remember the formula gave you, flow is equals to change in pressure or pressure gradient over resistance. So yes, the resistance is low, fine, because veins have wider lumen and the lumen keep on increasing. So the resistance could be low, but it's not zero, but it's low. But the change in pressure is also very low. And that will make blood flow through the veins to be very difficult. So this pressure is usually too low, and it may not be enough to promote adequate venous return. The venous pressure is too low to permit or to promote adequate venous return. For that reason, some other parameters must come into play to help blood in the veins go back to the heart. What are those parameters? What factors will promote venous return? Well, one of them is the pumping action of the heart, which creates the pressure in the arteries. And so that is why we have that pressure gradient that you talked about. But we are saying that pressure gradient is low. So apart from that pressure gradient that we already have, what are the other factors? Veins have valves that ensures that once blood has gone up, it can't go back. They allow unidirectional flow of blood. So that will help to promote venous return. The veins within the limbs are between muscles. When muscles contract, they push blood within the vein upwards through valves. And so during relaxation, that blood will not go back because you have valves. That is particularly important for the veins in the lower limbs. That is why you would encourage your patients to be ambulant so that they can promote venous return. Vena comitante is a situation where you have two veins running on either side of a single artery. Vena comitante has two important roles, advantages. One is that the artery has warm blood. It's coming from the heart anyway. The veins are coming from the peripheries, so the blood could be very cold. This arrangement of two veins on around one artery help to warm the venous blood as that blood goes back to the heart. This is a mechanism of warming venous blood. But it's also a mechanism of promoting venous return. How? The pulsations of the artery translate onto the vein. And so that will give it somewhat a push similar to what the muscles are actually doing. So if you couple that with the fact that the veins will have valves, then it means that once a particular segment has been, the blood in a particular segment has been pushed forwards, it can't go back because of the veins, because of the valves. Vena comitante help to promote venous return. The movements of the thoracic cage, especially during the inhalation phase, will also promote venous return. How? During inhalation, the thoracic cage expands. So the volume increases, but that means that the pressure within the thorax reduces. That negative pressure within the thorax helps to pull blood in the vena cava back to the heart as well. Lastly, gravity may have a role in promoting venous return on condition that the vessels you're talking about are located above the heart. Think about blood from the brain, for example. Gravity can help that blood to move back to the heart. But understand that gravity is also a factor that inhibits venous return if you're looking at the veins that come from the lower part of the body, like the veins in the lower limb. They struggle against gravity to take their blood back to the heart. So these are the factors that promote venous return. if you look at them in a different way, and I want you to look at them this way, that veins need some help. Imagine you are climbing upstairs. Now you are the vein, you are climbing upstairs. Sometimes for you to climb up the stairs, you can have your own energy within, but if you don't have, then how will you climb the stairs? Somebody can push you from behind and you'll still climb up the stairs. Someone can pull you from the front and you still have to climb the stairs. And maybe as somebody is pulling you or someone is pushing you, you may also be supporting yourselves on the rails of the stairs. Maybe if I give you a push, then you hold so that you don't go back. Then another push, you hold. So out of these 6 factors, I want you to think through which ones are the push factors, which ones are the pull factors, and which ones are the support factors. I'm giving you 30 seconds again for that. Which ones are the pull factors, which ones are the push factors, and which ones are the support factors, the holding factors. You have 30 seconds. Okay, I think you've thought through that now. We can proceed. So let's go back to the arterial blood pressure. We talked about arterial blood pressure, capillary pressure, and venous pressure. But let's go back to the arterial blood pressure and think through the formula I gave you as you want to go through this. There are some key parameters that determine the arterial blood pressure. And one of them is cardiac output. Remember, cardiac output is simply the blood flow. So blood flow affects blood pressure. The formula I gave is that F is equals to P, change in P over R. So you must have worked out that formula. And so you know how cardiac output affects P. You must have gotten something like P is equals to cardiac output, or F, times R. So that's P. Think through the factors that contribute to cardiac output. So they'll also affect blood pressure here. Remember, cardiac output is the amount of blood that flow out of either ventricle in 1 minute. It's a function of heart rate and stroke volume, which means stroke volume affects blood pressure. Heart rate affects blood pressure. If the heart rate is high, the blood pressure will be high. If the stroke volume is high, blood pressure will be high. The volume of blood itself also affects blood pressure. If your blood volume is high, your blood pressure will be high. Because blood volume affects cardiac output, it will affect the end diastolic volume, and that will affect the stroke volume. If your blood volume is low, your blood pressure will be low. That's why if you bleed a lot, you'll be hypotensive. Peripheral resistance was the other factor that we talked about, and I told you why we prefer to use peripheral resistance, because that is where much of the resistance is experienced. There are parameters that affect resistance that I told you, but the key one that I told you affects resistance is the vascular diameter. Remember that formula, F is equals to change in P over R. So if you go back to the assignment I gave you about thinking about that formula and rearranging it, we can say this. P is equals to F times R. And remember, F is blood flow. But if we look at the whole circulation, then that blood flow is actually cardiac output. So therefore, with confidence, we can say that blood pressure is equals to cardiac output times total peripheral resistance. This is F, and that is R. Remember, cardiac output is a function of the stroke volume and the heart rate. Stroke volume is the volume of blood that is pumped in a single contraction. It will be influenced by the blood volume. If blood volume is high, the end diastolic volume will be high, and so the stroke volume will be high. If blood volume is low, vice versa. Stroke volume is also influenced by the contractility of the heart, the force of contraction of the heart. If the heart contracts strongly, then the stroke volume will be high. If there's a weak contraction, the stroke volume will be low. Remember the parameters that will affect blood volume, things like amount of fluid intake, renal function, and the like. The things that will influence contractility, sympathetic and parasympathetic effects on the heart, drugs, some hormones like thyroid hormones and adrenaline, they affect contractility. Heart rate is also affected by many things, sympathetic and parasympathetic input, hormones, exercise, anxiety, all those things affect the heart rate. Drugs, coffee, many things. How about the vascular diameter? The lumen of the blood vessel is influenced by the degree of vasoconstriction and vasodilation. And that is also affected by many things, like the autonomic nervous system. Sympathetic discharge in particular is an important determinant. The viscosity of blood, we said, is also a determinant of resistance. But remember, we said viscosity does not change much for any particular individual. As long as most things are constant, viscosity will be constant as well. The length of blood vessels is another parameter that doesn't change much as long as it's one individual we're talking about. So vascular diameter is a major determinant, but that does not tell you, that does not mean that now we have to ignore this one. You may have some pathological conditions, I told you, like in polycythemia, where now blood is very thick, and so those people will be hypertensive. I want us to also understand that vessel compliance is also an important parameter that contributes to vascular diameter. And this is actually where age comes in. You know, vessels are supposed to be compliant, which means the ability to distend and go back when that pressure has gone. We want arteries to behave that way. During systolic pressure, they should distend to allow that pressure, to allow that force, so that there's not much pressure on the vessel wall. Then when that systole goes away, the artery should go back narrow so that it can maintain the blood pressure. Now, if the vessel is not compliant in that nature, then it means that it will be offering a lot of resistance to flow because not compliant. And this is what happens with age. With age, our vessels lack their compliance. And that is why the resistance increases with age. And that is why pressure is a disease of the older people predominantly. Hypertension, I mean. Now, the changes in one variable if you change heart rate, that will threaten to change blood pressure. If you change contractility, that will threaten to change blood pressure. However, we don't see that happening a lot. And the reason is there. Usually when you have a change in one variable, the other variables quickly compensate for that to try to make sure that the pressure is constant. Now that's the normal physiology. If you have a change here, for example, okay, let's say here, if you bleed a lot, for example, so your blood volume goes down, your stroke volume goes down, the heart rate will automatically be increased so that you can try to compensate. So that's what I mean, that when you have a change in one variable, usually homeostatic mechanisms of blood pressure come into play to try to compensate for the change. So I may not go again into this slide with detail because I've already tried to summarize for you all those factors that determine blood pressure. And so at your own time, you can also have a look at this and see. And in this slide, I'm looking just at the factors that affect cardiac output. Exercise will affect cardiac output. Because if you exercise, then you are actively using your muscles. The heart is pumping more. There is a lot of sympathetic constriction. There's a lot of muscle pumping. The respiratory system is active. So venous return is increased. If venous return increases, the end diastolic volume is increased. And so the stroke volume increases. That means cardiac output increases. If you have a fall in blood pressure, for example, the brain will detect that fall in blood pressure and initiate sympathetic activity. When you initiate sympathetic activity, that will increase heart rate automatically. That will increase blood pressure. But again, it will cause adrenaline to be released into the circulation. It's a hormone. It will also increase heart rate automatically. But it will also have a positive inotropic effect. Sympathetic activity also has a positive inotropic effect, and that will lower the end systolic volume because the heart will contract forcefully, so it will pump so much blood out of the heart in a single contraction. If you lower the end systolic volume, and on one end you've elevated the end diastolic volume, you are increasing the stroke volume, even if that EDV was constant. If you lower the ESV, you still increase stroke volume because we said stroke volume is equals to end diastolic volume minus end systolic volume. So you can see the things that affect cardiac output. And remember, even blood volume will affect cardiac output as well because it increases the end diastolic volume. Now let's look at the short-term and long-term mechanisms of blood pressure regulation. We'll start with the short-term mechanisms of blood pressure regulation. There are two short-term mechanisms. We have neuronal mechanisms and we have hormonal mechanisms or endocrine mechanisms. Let's start with neuronal mechanisms. So the neuronal control of blood pressure largely relies on receptors that detect pressure and receptors that detect the concentration of oxygen, carbon dioxide, and hydrogen ions in the circulation. So remember, baroreceptors detect pressure. The chemoreceptors detect the concentration of oxygen. carbon dioxide, and hydrogen ions in the circulation. These receptors are located within blood vessels, as well as within the central nervous system. The reflexes these receptors initiate are integrated within the cardiovascular system of the medulla oblongata. So the medulla oblongata is part of the brainstem. It has a center that controls the heart. We call that the cardiovascular center. Cardiovascular center control heart functions. Sometimes we call that the cardiac center, and control the blood vessels. We call that the vasomotor center, but let's just call it the cardiovascular center. It is located within the medulla, controlling both the heart as well as blood vessels. So the information that come out from the cardiovascular center of the medulla travel via autonomic nervous system. And the key target organs are the cardiac musculature, myocardium, and vascular smooth muscle. So that will be on the blood vessels. And this other one will be on the heart. Of course, we know that there's also that output that goes to the adrenal medulla that causes release of adrenaline. Then adrenaline will still act on the cardiac musculature as well as the vascular smooth muscle. Remember, Tunica Media of the blood vessels. So if you have information that targets the cardiac musculature as well as the vascular smooth muscle, contraction and relaxation of those muscles will either alter the cardiac output eventually or will alter the total peripheral resistance. Remember the formula for BP. BP is equals to CO times peripheral resistance. So these are the two arms of the blood pressure that will be affected, and they're the ones being targeted in this case. So let's imagine a scenario where the blood pressure has gone up for whatever reason. If the blood pressure goes up, the receptors which are on the walls of arteries will detect the rise in blood pressure. So they could be found on the walls of the internal carotid artery. We call it the carotid sinus. The carotid sinus is a region within the internal carotid artery that detect blood pressure. But not just carotid sinus, the aorta also has those receptors within its wall. And actually, most big blood vessels in the head region have those receptors within their wall. So they're just baroreceptors. If the baroreceptors detect a rise in blood pressure, that information goes to the brain. The cardiovascular center is in the medulla. What happens? We will have information from the medulla that will reduce the sympathetic outflow. So if you have a reduction in the sympathetic discharge, what are we going to have? Negative chronotropy, negative inotropy, which means a reduction in heart rate and a reduction in contractility. If you reduce contractility, you reduce stroke volume, you'll reduce cardiac output. So there'll be a reduction in cardiac output. Just by inhibiting the contractility and the heart rate of cardiac muscle. To the blood vessels, there'll be relaxation of the vascular smooth muscle, and that causes vasodilation. So reducing peripheral resistance. And so there'll be a fall in blood pressure. The blood pressure is restored to normal. How about if the blood pressure was low. If the blood pressure falls down below normal, again, that will be detected by the receptors, the baroreceptors on the vessels. And that information goes to the cardiovascular center of the medulla. That will cause increased sympathetic discharge. And so you'll have those positive chronotropy, positive inotropy, and eventually increasing cardiac output. But you'll also have vasoconstriction. Remember, this one uses alpha-1 receptors. The other one uses beta-1 receptors. Eventually, you'll increase resistance and increase cardiac output, so we'll increase blood pressure to normal. So those are the neuronal mechanisms. I want you to understand that the neuronal mechanisms are aimed at maintaining the mean arterial pressure on a moment-to-moment basis. It can change even within 1 second. So it's an active thing going on even right now in you. It's a moment-to-moment basis. The neuronal mechanisms are aimed at protecting the circulation against short-term changes in blood pressure. So you don't want an abrupt change in blood pressure. So this protects the body against that. That's why it helps you if, let's say you are lying down, then you suddenly stand up. These are the mechanisms that help so that blood still goes to the brain, even if you just abruptly stood up from a lying position. Well, of course, we know that there'll be those occasions that will feel slightly dizzy, but if you didn't have these neuronal mechanisms, it will be worse. Neuronal mechanisms also alter distribution of blood to respond to specific demands of various organs. For example, they're able to alter blood flow to a particular organ and not another at any given time. They can make blood to go much to the heart and less to the liver, for example, or less to the intestines. They can make blood to flow much to the skin and less to other structures, for example. So they alter distribution based on demand. But one last thing I want to say about these neuronal mechanisms is that they ensure that there are some 2 vital organs that receive as much blood as possible in low blood volume conditions. In conditions where the blood volume is low, maybe you've bled or it's just anemic, they ensure that the brain and the heart are still favored either way. That's the role of neuronal mechanisms. Now we can look at the endocrine mechanisms. The endocrine mechanisms, which are short-term. So these rely on hormones that operate largely to control the peripheral resistance, although they can still control the heart, but they're largely affecting the peripheral resistance. Now think about the hormones that control blood pressure. There are many. The catecholamines, we can start with those ones. We know that they increase cardiac output, but how? Sorry, they increase blood pressure, but how? They increase cardiac output by increasing heart rate and contractility. We also know that they increase blood pressure by increasing resistance because they cause vasoconstriction. The other hormone is angiotensin II. Angiotensin II increases blood pressure because it causes vasoconstriction. So its targets are blood vessels. The other hormone is atrial natriuretic peptide. I want to look at this one and realize that out of all those hormones I'm mentioning, this one, its arrow is facing down. ANP reduces the blood pressure. Now, the mechanisms are multiple, but one of them is that it lowers the peripheral resistance because it causes vasodilation. The other mechanism ANP uses is that, remember from that name, atrial natriuretic peptide. So it's produced by the atrium of the heart. Natriuretic means it promotes loss of sodium in urine, and peptide means it's a protein. So this protein hormone promotes loss of sodium in urine. If it promotes loss of sodium in urine, even water will follow. If water follows, you lower the blood volume. So it will still act through alteration of blood volume to lower blood pressure. Although the changes which affect blood volume tend to be long-term mechanisms of blood pressure regulation. And that is why we've not put that one in this list here. Antidiuretic hormone usually has also two effects. It will increase blood volume because it reduces water loss, and that's a kidney mechanism. Again, that's a long-term mechanism more than a short-term mechanism, but a short-term mechanism would be it causing vasoconstriction and so increasing resistance. Aldosterone increases blood pressure because it increases blood volume, because it reduces water and sodium loss in urine. Again, tend more to be a long-term mechanism, but it can also act in a short-term basis. So what I want to capture about the short-term regulation and hormones is that you just mention a hormone and you state its role in blood pressure. Now we can talk about the long-term mechanisms of blood pressure regulation. The long-term mechanisms of blood pressure regulation rely on the kidney. These mechanisms are aimed at altering the blood volume. So there are two types of renal mechanisms of regulation. There's what we call the direct renal mechanisms and the indirect renal mechanisms. Let's start with the direct renal mechanism. The direct renal mechanisms do not rely on the hormones, but they depend on the rate at which fluid is filtered from the bloodstream into the renal tubules. Let's think through that. If blood pressure is high, it means that more fluid will be filtered. If fluid being filtered into the renal tubules is moving at a faster rate, then it means that the amount of fluid we are going to lose out of the kidney in form of urine is also high. So what's the long-term effect? You'll lower the blood volume. And so that's a direct mechanism. Anytime the blood pressure is high, the glomerular filtration rate is high, urine output is high, and that automatically lowers blood volume, which will lower the blood pressure. It's a direct mechanism. Don't think too much about it. How about if the blood pressure is low? If the blood pressure is low, there'll be less GFR. And that means that the urine flowing through the renal tubules will also be moving slowly. There is enough time for reabsorption. So if there is slow flow, much contact time, and so much tubular reabsorption, there'll be a lot of fluid being reabsorbed, less urine being lost. That means you'll be having fluid retention. The aim will increase blood volume, hence blood pressure. I hope you've understood the direct renal mechanisms. Now let's talk about the indirect renal. Okay. Yes, maybe before that. So the direct renal mechanism is just based on what I've told you. The indirect renal mechanism relies on the renin-angiotensin-aldosterone system. And I want to talk about that renin-angiotensin-aldosterone system. It is the indirect renal mechanism of blood pressure regulation. Okay, I've already told you that the indirect renal mechanism relies on the renin-angiotensin-aldosterone system. Let's talk about it. So we have something called angiotensinogen. It is a protein produced by the liver. This angiotensinogen is released into the circulation. So it just flows in the bloodstream. It's one of the plasma proteins, actually. Angiotensinogen become converted to angiotensin 1 in the circulation. The conversion of angiotensinogen to angiotensin 1 is facilitated by an enzyme called renin. Renin is an enzyme that comes from the kidney. The cells of the kidney that produce renin are called the juxtaglomerular cells. In what circumstances will the liver produce renin enzyme? If the blood pressure falls, the kidney will produce renin. If the levels of sodium in renal tubules is low, that equates to the levels of sodium in the circulation are probably low. The kidney will produce renin as well. Or if you have increased sympathetic activity, the kidney will also produce renin. So in those circumstances, the kidney produces renin. And so renin enzyme, I want you to know, renin is not a hormone, it's an enzyme. This renin enzyme converts angiotensinogen to angiotensin 1. That conversion occurs in the circulation. So even if renin is being produced by the kidney, it doesn't mean that that conversion occurs in the kidney. Then you have angiotensin 1 being converted to angiotensin 2. The conversion of angiotensin 1 to angiotensin 2 is facilitated by the enzyme angiotensin converting enzyme. This angiotensin converting enzyme is produced by the endothelial cells of the lung capillaries. So the lung capillaries usually produce angiotensin converting enzyme. This enzyme is the one that converts angiotensin 1 to angiotensin 2. So we have angiotensin 2 being the active hormone that you want to talk about. Angiotensin 2 has multiple target organs. 5 of them actually. The blood vessels, the posterior pituitary gland, the adrenal cortex, and the proximal convoluted tubule of the kidney. Well, the 5th one is the hypothalamus itself. And because the one of hypothalamus is not in this slide, I will finish with it, but let me describe these ones first. Now, that means that the receptors of angiotensin 2 are present in all those sites. When angiotensin 2 acts on blood vessels, it causes the blood vessels to vasoconstrict. So that's the physiological effect of angiotensin 2 on blood vessels. It is for that reason that we call it angiotensin, because it causes tension on blood vessels, vasoconstriction. On the adrenal cortex, angiotensin 2 acts on the outer zone of the adrenal cortex. The outer zone of the adrenal cortex is known as zona glomerulosa. Well, the adrenal gland has two parts, the adrenal cortex and the adrenal medulla. The adrenal medulla produces catecholamines. The adrenal cortex produces steroid hormones, or what you want to say, corticosteroids, steroids from the adrenal cortex. But this adrenal cortex has three zones. Outermost zone, zona glomerulosa. It produces hormones that affect mineral levels, and aldosterone is one of them. Second zone, zona fasciculata, produces hormones that affect glucose levels or carbohydrate metabolism. So we call them glucocorticoids. Third zone, zona reticularis, produces hormones which are similar to the male sex hormones. So they're androgens, basically. We are not talking about the other zones of the adrenal cortex. In particular, we are talking about the zona glomerulosa. So angiotensin 2 causes the zona glomerulosa to produce aldosterone, which is the main mineralocorticoid. The other zones of the adrenal cortex are stimulated by other things, not necessarily angiotensin 2. What's the effect of aldosterone? Aldosterone acts on the distal convoluted tubule of the kidney. And the effect of aldosterone is to promote the reabsorption of sodium. Now, in the kidney, if we reabsorb sodium, water also follows. And that means that in the presence of aldosterone, we have sodium and water retention. In particular, the reabsorption of sodium is usually in exchange with potassium. So we can say that aldosterone promotes potassium loss in urine, but at the same time promoting sodium reabsorption, and water follows as well. That is why the diuretic drugs that inhibit aldosterone are known as potassium-sparing diuretics. Because if you inhibit the effects of aldosterone, it means that you're not going to reabsorb sodium and water. So you're going to lose water in urine, that is diuresis. But again, it means that the potassium in the circulation, you're not going to lose it in urine. Because ideally, aldosterone was to facilitate sodium reabsorption in exchange with potassium. So if you inhibit aldosterone, potassium remains in the circulation and sodium remains in the renal tubules together with water. Those drugs that inhibit aldosterone are potassium-sparing diuretics. They spare potassium. All right. Angiotensin 2 also acts on the posterior pituitary gland. The name given to the posterior pituitary gland is neurohypophysis. So it acts on neurohypophysis to cause secretion of antidiuretic hormone. Antidiuretic hormone is also called vasopressin. So it promotes the secretion of vasopressin. Vasopressin acts on blood vessels to cause vasoconstriction. And that is why it's called vasopressin, actually, because it causes vasoconstriction. Vasopressin also acts on the kidney itself, especially the collecting ducts of the kidney. What's the effect there? It acts on the collecting ducts of the kidney to promote the reabsorption of water. And that is why we call it antidiuretic. So if you promote water retention, it means that in the presence of ADH, you just produce little concentrated urine. Right. So that we have water retention, we have vasoconstriction. How about the PCT, the proximal convoluted tubule of the kidney? Angiotensin 2 acts on the proximal convoluted tubule of the kidney to also promote sodium and water retention. Now remember, it's not the DCT, but the PCT, and it also promotes sodium and water retention. So I've told you those sites: blood vessels, neurohypophysis, zona glomerulosa, and PCT. I told you that there's another site that angiotensin II acts, and that is on the hypothalamus. On the hypothalamus, angiotensin II increases the sensation of thirst. So if it stimulates the sensation of thirst, how will you respond? By taking more water. And if you take more water, it means that you are increasing blood volume, basically. Another thing, angiotensin II may also increase sympathetic discharge. It may have a role in increasing sympathetic stimulation. If you increase sympathetic stimulation, you're going to increase vasoconstriction. Of course, well, it'll also affect the cardiac output. Anyway, we see that all these converge under two umbrella. Increased vasoconstriction increases the total peripheral resistance. Sodium and water retention increases blood volume, and that will have an effect on cardiac output. Of course, if you take water because of thirst, you also increase blood volume. So renin angiotensin aldosterone system in overall raises the arterial blood pressure. And that is why some antihypertensive drugs particularly target this one, because you see that renin angiotensin aldosterone system is a long-term mechanism of blood pressure regulation. And so the drugs that target this system may give us some long-term effect of management of blood pressure. Remember, if you inhibit this system, then you lower the blood pressure. If you activate this system, you will increase the blood pressure. So antihypertensive drugs that inhibit this system will basically lower the blood pressure. Maybe you know some of those ones. For example, here, there's some drugs that inhibit the conversion of angiotensin I to angiotensin II because they inhibit this enzyme here, angiotensin converting enzyme. We call them the S inhibitors, angiotensin converting enzyme inhibitors. They usually end with the term pril, enalapril, captopril, and the like. Then there's another entity that act here at the receptors of angiotensin II. So we call them angiotensin II receptor blockers, the ARBs. They end with the term sartan. Well, there's an R somewhere, sartan, losartan, candesartan, and the like. So those ones are ARBs, angiotensin II receptor blockers. Of course, I've told you that those drugs that inhibit aldosterone receptors, so those ones are basically potassium sparing diuretics. They're also used in the management of blood pressure. Right, so that's the long-term mechanism of regulation of blood pressure using the renin angiotensin aldosterone system. We can see the effects on the sympathetic system, proximal convoluted tubule, adrenal cortex, vasculature, and neurohypophysis. The one not shown here is the one to the hypothalamus, which increases thirst sensation. Hence, you take water, and so increasing blood volume. Great, so I want you to be familiar with the parameters that affect blood pressure. Many things affect blood pressure. I have tried as much as possible to give you a summary of them. Remember, at the end of the day, they work by either increasing cardiac output or increasing resistance. All right. So that will be the end of it. I know it's been long, but I think you've understood vascular physiology in a better way than you knew before. Thank you. We'll stop there.